Antepartum complications mini lecture. So we are just going to talk about the differences in some antepartum complications, give you guys a little bit of material to think over before class. So one of the most common complications is bleeding during pregnancy. Now there are a bunch of different reasons for bleeding to occur, but none of them are to be assumed normal. So we always need to evaluate what is the cause of the bleeding, the maternal fetal status as a result of the bleeding. So it doesn't necessarily mean the end of pregnancy. It doesn't necessarily mean that interventions are necessary. It just means that we need to evaluate. So we kind of differentiate the causes of bleeding by whether they're occurring in the first trimester or the second trimester or later. So in the first trimester, we have a couple different things that could cause vaginal bleeding. It could be the potential miscarriage or spontaneous abortion, and there are a couple of different levels of miscarriage. We have threatened, inevitable, and complete. Threatened means that there is vaginal bleeding, but the cervical os, the cervical opening, is still closed. So that vaginal exam where we talk about if it's dilated or effaced or anything happening, if it's a threatened miscarriage, that means that there is vaginal bleeding, but the cervical os is closed. If it is an incomplete, that means the cervical os is open, so the cervix is open. There might be some passing of fetal placental tissue. And then if it's complete, that means all products of conception have been expelled. Now, sometimes a woman might get stuck in that process. So let's say that her body is attempting to miscarry, but the body is not able to expel all the contents of conception on its own. That is where we could intervene with medical or surgical means. A subchorionic hemorrhage is essentially, if you think of like a hematoma or a big, large blood clot, that is underneath the placenta, between the placenta and the uterine wall, but it's not causing any issue usually to the pregnancy. Most of the time it gets expelled on its own, and most of the time it's fine. This can be diagnosed on ultrasound. Implantation bleeding is often termed as spotting after a pregnancy occurs. What happens is when that fertilized egg is attaching to the uterine wall, to the uterine lining, there might be a small amount of spotting as a result. So typically this is a couple, usually about 1 to 2 weeks following ovulation, but it's not an exact science. Sometimes if a woman has already taken a pregnancy test and got a positive on the pregnancy test from those hormones, but then she starts having this spotting, it can be very concerning, but usually it's a light amount of vaginal bleeding. Ectopic pregnancies is a very serious issue. This is a result of a fertilized egg attaching to the fallopian tubes instead of within the uterus. Ectopic pregnancies cannot be salvaged. If the fertilized egg is attached in the tube, there are a couple different ways of going about fixing that problem. The only fix to that is removing the pregnancy. So we can either do that with medical means to create a medical abortion or surgical means. And a lot of that depends upon the status of the ectopic pregnancy at the time of discovery. If it is not ruptured, if it is intact and small and isn't causing a huge amount of issues systemically to the mom, medical means might be the way to go. However, if it ruptures the tube, more than likely that's going to require surgical management. This is a very severe complication to mom. So ectopic pregnancies can actually kill a mother if it's not diagnosed and intervened upon appropriately. A molar pregnancy is something that's far more rare, but is very serious. So what happens is the egg fertilizes like normal. It attaches to the uterus like normal. It begins dividing into more and more cells. However, at some point in that division, it proliferates into something that is no longer a pregnancy. It's called a hydatiform mole. We're going to look at pictures of this in class and explain a little further. But this is it overtakes the pregnancy. It kills off the pregnancy and turns into this essentially almost like a tumor that's growing within the uterus that needs identified and removed as soon as possible. There is the risk of the molar pregnancy turning into a cancerous substance within the uterus. So early assessment diagnosis and intervention is preferable. If the bleeding occurs in the second trimester or later, most of the time, it's due to one of these four things. So we have placenta previa, which we talked about a little bit in class already. This is just the attachment of the placenta over the cervix. So if a mom has a diagnosed placenta previa, they will more than likely experience painless vaginal bleeding. So it doesn't cause them pain, but they will have sometimes a very significant amount of vaginal bleeding. If a mom has a known placenta previa, she is going to be a C-section for delivery. She's also going to be what we consider pelvic rest throughout the pregnancy once this is diagnosed. So no sexual activity, no objects into the vagina, low level of activity if they have a high risk for bleeding or if they've already bled multiple times. Most providers are kind of have a 3-strike rule with bleeding. So if they have 3 major bleeds, once they have that third one, they are housed inpatient until delivery. Just because sometimes, like I said, that amount of bleeding can be pretty significant. Placental abruption is that premature separation of the placenta from the uterine wall while the pregnancy is still intact. This can be a small marginal abruption. It can be a complete abruption. Most of the time, if it's early on in pregnancy, we're seeing a small marginal amount that is going to be a chronic problem. The diagnosis of placental abruption can be made on ultrasound. Most of the time, the mom has abdominal pain, sometimes cramping or contractions associated with that. And we may or may not see external vaginal bleeding depending upon the portion of the placenta that is detached. Vasoprevia, we are going to talk more thoroughly about in class. It's easier to describe with pictures, which I have in the PowerPoint for you. Vasoprevia is when the connection between the umbilical cord and the placenta, those vessels, that 2 arteries in 1 vein, remembering what we expect those 3 vessels to be, is connected to the placenta in a way that is not protected. So we have open vessels. We don't have that Wharton's jelly and that protective covering over the umbilical cord. It's open vessels, which we know vessels are very fragile. And if those vessels were to rupture, mom and baby would both have a catastrophic amount of blood loss very quickly. This is also can be diagnosed on ultrasound, and we'll talk about the care of that moving forward in a pregnancy after diagnosis more in class. And then we often have what we call spotting after vaginal exams, which is very common during pregnancy. So if we're doing a vaginal exam on mom, that cervix is very vascular and it's very friable, it's very sensitive. So with that irritation and manipulation of vaginal exams, moms might have a little bit of vaginal bleeding spotting level after those vaginal exams, and that is considered normal. We don't get too caught up in that. Usually it's a very mild amount of bleeding. Premature and prolonged rupture of membranes. So we know that after mom's water breaks, after that's occurred, within 24 hours, after we hit that 24-hour mark, we increase our risk for infection, right? If this occurs and the gestational age of the pregnancy is greater than 4 weeks. So if we have rupture of membranes after 34 weeks, we move towards delivery, regardless of what method that is. If the gestational age is less than 34 weeks and we have rupture of membranes and mom and baby are both reassuring in their status, we tend to keep them pregnant until we hit that 34-week mark. So it is possible that a mom can be ruptured for weeks, sometimes month or 2, until we get to that 34-week mark if mom and baby are reassuring. So what does that look like? Most of the time that's inpatient care for mom, close monitoring of mom and baby, usually frequent vital signs, palpation for abdominal tenderness, uterine tenderness, because that can be a sign of infection, frequent monitoring of baby on the fetal monitor, usually at least daily NSTs, if not more frequent. Latent antibiotic therapy. So if we think there's an underlying infection or that could have caused the rupture, moms typically get 2 days of IV antibiotics and 5 days after that of PO antibiotics to treat anything underlying and or prevent an initial infection. We do frequent ultrasounds for AFI or amniotic fluid index and fetal growth. So we know that if mom's ruptured, that AFI is going to be lower, right, than we would expect in an intact membrane. However, baby will continue to make amniotic fluid, and we like to monitor those levels, because if there's no fluid at all, that's worse than some fluid or low fluid. So we monitor those frequently. Bed rest for mom is pretty typical. We will usually do betamethasone or corticosteroid injections for fetal lung development, remembering that that's 2 doses 24 hours apart. For anybody that we think is more than likely going to deliver early. And we know that if they're ruptured, we're going to be delivering them at 34 weeks at the latest, if they're ruptured before that. And of course, that increases risk for infection for both mom and baby and increases the risk for prolapsed cord. So we look out for those things very, very closely. Gestational diabetes, which most of these risks are also increased with, type 1 or type 2 diabetes, but we're going to focus more on gestational diabetes because that's specific to our OB population. So gestational diabetes is a direct result of the placental influence on hormone regulation in the body, remembering that insulin is a hormone. So obesity and familial history of diabetes does increase the risk for gestational diabetes. However, it is just almost solely due to that placental function and influence. So even a healthy, active, woman that is of normal size can develop gestational diabetes through no fault of her own. This increases the risk for baby, so fetal macrosomia, birth trauma as a result of that macrosomia, and then hypoglycemia and issues after delivery, like we've talked about in the newborn content. We have a much tighter control expectation for blood sugars in the pregnant woman than we do the non-pregnant adult. So we typically say less than 90 for fasting blood sugars and less than 120 for 2-hour postprandials. If you remember your diabetes content from MedSurg, this is very much tighter control than we would expect for a non-pregnant adult. And that is directly related to risks for baby, is why we expect those numbers to be so much lower. We first will start out with diet control for gestational diabetes. Sometimes that works and sometimes it doesn't. Even if the mom is completely compliant in the diet management, sometimes those sugars are still higher than we would like. So we can use oral medications and or insulin management. Most of the time, especially if mom is compliant with the diet and carb counting, it's the fasting blood sugar that is hardest to control. So sometimes a little insulin before bed helps that fasting blood sugar level. But each woman is very independent and has independent management of that. Gestational diabetes is very difficult to control. We frequently do ultrasounds to monitor for fetal growth, make sure baby is on track and not getting that to that macrosomic range. And then we diagnose gestational diabetes with a 1-hour and 3-hour glucose tolerance test. And this is typically done at the 28-week mark. The 1-hour test is done first. It's 50 grams of a glucose solution. We do a 1-hour blood glucose level following the ingestion of that solution. If it's higher than 140, we consider that a failure. If it's less than 140, mom passes and she's all done. She doesn't have gestational diabetes. If it's higher than 140, we do a 3-hour glucose test in which we give mom 100 grams of that solution. We do a fasting 1 hour, 2 hour, and 3 hours after ingesting the solution, blood glucose levels, and there are strict numbers that we go by. I am not going to make you memorize the numbers for the 3-hour glucose tolerance test. Just remember 140 for the 1 hour. But if mom fails that 3-hour glucose tolerance test, then we diagnose her with gestational diabetes. We set her up with a dietitian to go over those diet control management kind of interventions, and then how to monitor her blood glucose. Typically, we're having these moms monitor their blood glucose for fasting and then 3 times after meals throughout the day. So at minimum 4 times a day, and then as necessary if they feel like their blood sugar is too high or too low based on some subjective symptoms. Preeclampsia, so hypertensive disorders in pregnancy, which we'll go into a little more in depth in class, but focusing just on preeclampsia, also very much tied to placental function and those influences and changes to the vascular systemically throughout mom. A lot boils down to those spiral arteries in the placenta, but I am not going to get to the level of that pathophysiology with you in class. So in a nutshell, we have high blood pressure, right? So mom's blood pressure is higher than 140/90 on at least 2 occurrences to be diagnosed with mild preeclampsia, and then greater than 160/110 on at least 2 occurrences to be diagnosed for severe preeclampsia. And then we have other assessment pieces as well. So proteinuria is a very large assessment piece. We do this with a 24-hour urine collection in which mom's protein in that 24 hours is over 300. We do urine dips, so the dipstick, reading 2 or 3 plus on dip, or we do a PC ratio, so protein to creatinine ratio. Typically, this is below 0.3, a PC ratio is, and if it's higher than 0.3, that would be indicative of preeclampsia. Some providers will use all three of these tests. Some just use one to diagnose. It really depends. But those are all monitoring of protein in the urine. Remembering that trace protein in the urine is normal for a pregnant woman, but no more than trace would be assumed normal. Central nervous system involvement often accompanies preeclampsia and makes us very concerned for the risk of seizure. This includes headache, vision changes, whether that be double vision, spots in the vision, tunnel vision, hyperreflexia. So remembering that DTRs are normal at 2+ and hyperreflexive at 3 or 4+. Clonus, which is also indicative of that decreased threshold for seizure because that central nervous system is heightened. Monitoring the urine output and concentration because kidney involvement is directly tied to those things. Edema, we typically see lower extremity edema first, but that's also common in just your normal pregnancy. So we also look at the degree of edema, especially pitting. After lower extremity edema occurs, usually with preeclampsia, we have upper extremity and facial edema, which is progressive. Right upper quadrant pain and liver enzymes are assessed for. This indicates liver involvement, which is also, as that preeclampsia progresses, that systemic influence. Let's see, we monitor for fetal growth. Preeclampsia increases the risk for intrauterine growth restriction and oligohydramnios, so that too little fluid, due to the decreased perfusion and oxygenation and growth of baby. So we monitor this via ultrasound, and then we also do frequent NSTs. If preeclampsia is diagnosed, we are monitoring usually NSTs at least biweekly, as often as twice a week, or maybe daily, depending on if it's severe and mom is inpatient. We can use oral antihypertensive for long-term management. We would only use IV antihypertensive for acute management of a blood pressure greater than 160/110. If we are giving mom, a pregnant mom, IV antihypertensives, we are monitoring baby when we do that. If we are aiming to drop her blood pressure very quickly, we have baby on the monitor monitoring the changes to baby's perfusion and tolerance of that, because we know that blood pressure is so highly tied to baby's perfusion. Magnesium sulfate is often used for seizure prevention. This also provides fetal neuroprotection, which we're going to talk about more in class. Betamethasone administration for any mom who we think we're going to deliver early. If mom has mild preeclampsia, we're probably going to go ahead and induce her around the 37-week once she hits term. If she's diagnosed as severe preeclamptic, more than likely we are inching towards that 34-week mark for delivery, or even sooner if it is really severe. Mom is, of course, at risk for seizures, stroke with that high blood pressure, and then HELLP syndrome, which stands for hemolysis, elevated liver enzymes, and low platelets, which we'll talk more about in class. So that is a quick run through of some of the most common antepartum complications, and we'll go more in depth when we are together next week.